Hello, I'm Alex Abbott. I'm a pediatrician turned primary care sports medicine physician, so I have a unique expertise helping young athletes with all kinds of sports injuries. I help take care of children through college age, and children and adolescents have important nuances to consider. So we'll talk about some common sports injuries for pediatrics. I'll introduce the topic with some of these unique nuances to pediatric orthopedics and sports medicine and provide an overview of what we see most commonly. I'll discuss overuse injuries like growth plate injuries and bone stress injuries, and acute injuries to include high yield fracture sites. And then we'll wrap up with a zoomed out perspective of what kids face socially as they navigate being student athletes. You might be tempted to treat children, especially those approaching college age, as adults with just less life experience. However, despite the possibly intimidating looking child with a beard who's towering over you in clinic, his musculoskeletal anatomy inside tells a different story. With the same injury mechanisms as adults, the open growth plates, or the physes, represent weak points in the chains of forces that are applied to similar systems. They're different systems to adults and they have the same sort of mechanisms, but there's different weak points. These growth plates are also with variable strength and they're weakest during periods of high growth velocity, so they're more susceptible to injury during growth spurts. On the right, you can see an adult, a teenager, and a child pitching. The adult and the teen to a layperson look very similar, and they might both present with medial elbow pain related to pitching, but inside, the teenager's differential looks a lot closer to the child's, which is significantly different from the adult's. Namely, we think about the very strong ulnar collateral ligament, that's the UCL ligament, being affected in adults once our growth plates are closed. But with an open medial epicondyle physis, the teen pitcher's weak point is more likely to result in apophysitis or an avulsion fracture, depending on the story and what your x-ray looks like. In addition to the dynamic structures because of those growth periods, variable hormone changes in boys and girls will also affect muscular growth rates. They will affect bone density, and there's other systemic variables such as sleep and tissue recovery. Growing pains, they don't just affect little kids, teenagers' growth plates and their bones. They continue to dynamically change and disproportionately change compared to the muscles and tendons during growth spurts. So that can contribute to significant problems with flexibility if teenagers don't have a good stretching program. So and essentially teenage athletes, they may talk a big game and they may kind of walk in with the swagger of the adult pitcher, but they are not flexible. They're still working on their motor skills and coordination. They're still working on their core strength and balance, and all of these things can mitigate injury risk in most sports. The physiology is not all negative for kids. The pediatric patients benefit from upregulated growth systems and a thick and vascular periosteum in their bones that allows them to benefit from really amazing fracture remodeling. These processes are more robust the younger the child is. You can see from these examples of fractures that would likely require surgery for adults that children can heal and remodel very well non-operatively. Children also demonstrate faster healing for tendon overuse injuries or tendinitis, and I'll talk about that further on another slide. So, if you take away just one thing from this lecture, even though some boys and girls may have excellent bone structure, unique haircuts, and legs that are heavy enough to make you question your arms routine when you're trying to examine them, children are not little adults. This year, we published a comprehensive study in J. Posna characterizing the epidemiology of musculoskeletal patients from a cohort of over 60,000 patients. This really cool figure from our study shows visually how the top 3 injury sites sort of shift as children age. Overall, in children, the most commonly injured bones were the radius, this was at 30%, usually at the wrist, the hand phalanx at 14%, and the humerus at 10%, which is usually at the elbow. Children seem to switch from falling off of changing tables to injuring themselves playing sports, and they also seem to gain coordination with time. You can see that illustrated by the fact that they're injuring more distally, and imagine that the more coordinated older children are stretching out their extremities before they're falling. However, the example of fibula fractures that is only entering the adolescent's top 3 sites doesn't likely reflect an issue with coordination, but more likely reflects the common distal fibula avulsion fracture, which happens when a big kid who still has open growth plates rolls his or her ankle. I'll talk about this a little bit more later, but this is a really cool illustration of the important intersection of big forces but still weak growth plates in adolescence. Our study also showed some interesting changes in fracture subtype likelihood by age. So babies have their moral reflexes and school-aged children have a Fuchs mechanism. So we're seeing babies and school-aged children having torus or buckle fractures most commonly. The softest bones in the youngest kids are seeming to be most likely to green stick or not break all the way through. And then again, high forces intersect with open growth plates as variables that those are most present in older children. So we're seeing the highest rates of avulsion and Salter-Harris fractures for those older kids. Finally, the graphic on the right shows that as boys and girls age, their extracurricular misadventures differ despite similar sport participation. So we see that baby boys and baby girls are similar in their fracture likelihood and fracture presentations, but teenage boys break their bones more often than teenage girls do. We'll zoom in now on some specific topics, starting with overuse injuries to look out for. When muscles are overused, they become strains with microfiber tears, pain, and inflammation. When tendons are overused, they thicken, inflame, they hurt, and they can progress from this acute tendonitis to a chronic tendinosis, where fibrosis starts causing scar tissue to form instead of normal tendon tissue. When bones are overloaded past their ability to strengthen, stress fractures or bone stress injuries can occur. We'll also talk about the other OCD, which is osteochondritis dissecans. And then finally, in prepubertal patients with open growth plates, the wear and tear affects them uniquely as apophysitis or growth plate irritation. Overall, these tissues accept exercise stimuli, they can remodel faster, but if athletes don't recover enough between sessions or they load too much too quickly, our scale tips toward damage rather than adaptation. Differentiating a muscular problem versus a tendon problem when you're concerned about a muscle strain or tendinitis is mostly a matter of the physical exam typically. Using the hamstrings muscles as an example, if your pain is very proximal or very distal to suggest an insertional location of pain, you might consider tendinitis over a muscular strain. If your patient's mostly tender over the middle, the muscle belly, then you start thinking about muscle strains. The reason why it's helpful to differentiate these is because muscles in general rehab more quickly than tendons, and rehab typically starts with stretching followed by strengthening for both injury types. But for tendinitis, we're usually more conservative. We try to be more respectful of the injury to avoid complicating it into tendinosis or tendon tears in the future. Rehab involves eccentric and isometric exercises for tendons that stimulates tendon more. So for the hamstrings, this would look like your Nordic curls, which are illustrated on the bottom right. When a patient's tendinitis is chronic and we start worrying about scar tissue, tendinosis, our arsenal starts to include pro-inflammatory modalities such as nitroglycerin patches, dry needling and 10x procedures, shockwave therapy, and PRP injections in sports medicine and orthopedics. Using ultrasound diagnostically can be really helpful for differentiating tendinitis and tendinosis, and ultrasound is often used to describe the procedures that I described on the previous slide. For our purposes, ultrasound and histology are helpful to educate and illustrate how the scarring process of tendinosis is shown on the right. You lose that linear and organized structure that gives tendons its strength. Instead, we kind of have these ugly blobs of scar tissue that do not contribute to tendon loading, and they force the remaining healthy fibers of tendon to work harder when the athlete is trying to remain active. As we discussed, when growth plates are the structures that are being affected by overuse, we call this apophysitis. Each of the growth plates close at variable time points throughout puberty and are all unfortunately named after people instead of their locations, so rote memorization is needed. Monasterio et al.'s 2021 study following over 500 injuries over 10 years in a group of elite adolescent soccer players provided this awesome visual about how peak height velocities seem to correlate in a way that growth plates are active and closing looks like from the ground up. So you can see severs at the heel affecting children when they are younger, and then issues through the pelvis and back like ASIS apophysitis and spondylopathy that starts affecting older children more frequently. However, we definitely need more studies to redemonstrate this pattern before we call it a rule that growth plates close from the ground up. Just in case some review is needed to remember the eponyms for the locations of growth plates, Iselin's is at the base of the fifth metatarsal, Severs is at the calcaneus, Osgood-Slaughter is at the tibial tuberosity below the knee, Sinding Larson Johansson or jumper's knee is at the bottom of the patella, and then Little League shoulder and elbow are at the proximal humerus and medial epicondyle, respectively. I'll show some examples of the more axial physes a little bit later. Going back to Monasterio et al.'s study, it also helps illustrate a concept that we discussed earlier, that once the growth plates are closed, the weak points now become the soft tissues like the muscles, tendons, and ligaments that attach. And so these become more of our frequent adult injuries or our skeletally mature injuries. Okay, so far we've talked about overuse injuries of the muscles, the tendons, and the growth plates. We've got strains, tendinitis, tendinosis, and apophysitis. Now we'll talk about when the bones themselves get overworked. When bones are loaded, similarly to the soft tissues, they can adapt to that stress over time. But when recovery or volume is not in balance, then the breakdown outpaces the buildup, and we can get bone stress injuries or stress fractures. These occur more commonly in adults than adolescents, but a recent 10-year study of over 10,000 sports injuries found that 42% of stress fractures were in patients who are younger than 20 years old. Stress fractures are most common in the lower extremities at the tibia, fibula, and femur, but they're also pretty common in the pars interarticularis, which is the projection of bone in the back of the spine that helps take stress during extension type activities. We call this injury spondylolysis. The sports where you see stress fractures the most are track and field and cross country, gymnastics, basketball, soccer. You should think about bone stress injury in an athlete who has high volume weight bearing, dramatic increase in exercise volume, and if you're concerned about emphasis of leanness or low energy availability. So we think about those aesthetic sports or leanness sports like running and gymnastics. Once you realize your concern for bone stress injury, the first steps are to obtain imaging. As you see on the right, bone stress injury can be visible on an X-ray, but it's important to evaluate with X-ray and MRI to rule out a more subtle or an early bone stress injury that's not visualized on an X-ray, and or grade it for prognosis and management guidance if there is one. I also always offer this panel that's described on this slide to help rule out organic contributors for poorly optimized bone health once a stress injury has been diagnosed. This can help you know that if a patient is resting properly and progressing back to their sport normally, there's not some sort of other primary etiology that's working in the background against you. If the patient's history or their blood work is suggestive of low energy availability, or if the patient is amenable regardless, I offer a nutritional consultation to make sure that the athlete is fueling properly. Stress fractures diagnosed at the lateral part or the tension side of the femoral neck, the patella, the anterior tibia, the medial malleolus, talus, navicular, second or fifth metatarsal, and the great toe sesamoids comprise our list of high-risk sites. This is because the nature of gravity, weight bearing, pulling the tension sides apart, and or suboptimal blood flow at these locations predisposes them to non-union and potential eventual need for surgical fixation. Bone stress injuries are initially managed with rest to allow bone healing. My typical instruction is that athletes can walk without use of boots or crutches if they don't have pain when they're walking, but I provide these if walking is painful for those lower extremity or axial sites. I also instruct that patients should refrain from weight-bearing athletics and can swim and engage in seated core, seated upper body exercises, and or swimming if they have lower extremity bone stress injuries. But I would consider greater restriction for axial locations like the spine, the pelvis, or the ribs. At Stanford, we use an evidence-based protocol for returning athletes with bone stress injuries who do not require surgery to weight-bearing activities. These goals are to allow fracture healing, followed by progressive loading to prevent recurrences, and keep our scale tipped in favor of adaptation and increased density instead of recurrent bone stress and breakdown. So phase 1 is our unloading phase for initial healing. Phase 2 involves relevant strength training for potentially deconditioned patients after the initial resting phase, as well as sort of testing the waters with longer duration walking over time. Phase 3 progresses athletes further with low impact cardio, weighted strength exercises, and progression to jogging. And then finally, athletes begin the return to running phase with return to sport specific activities as the goal. The phases can take 3 months or longer to complete overall, and the emphasis for pain-free activities and slowing or halting the progression with recurrent symptoms are really important emphases. At the fastest through this protocol, the athletes will move from injury diagnosis back to competition in around 4 months. But some athletes need more time than this, and some end up needing surgery to achieve bone stress injury union. I describe that taking shortcuts through the phases, not reporting pain, or otherwise trying to skip ahead can paradoxically make the return to sport process take longer. I also describe that it's quicker to progress through the phases at an appropriate pace, even if it's slow, than to go back to the first phase over and over again because of injury recurrence. I included the next overuse injury, osteochondritis dissecans, after our bone stress injury discussion because the treatment is similar and it's also similarly frustrating for athletes, a prolonged period of rest. The mechanism for bone cartilage dissolving, which is the lame person's translation for OCD, that mechanism is not well described, but it seems to be related to blood flow interruption at an epiphysis of a highly and repetitively loaded bone. Patients can present with chronic pain with OCD lesions that are found radiographically, or they can have an acute injury that seems to have exacerbated or had a predisposition from a previous existing lesion. An important nuance for OCDs in the knee, the notch view, which is your fourth view of your complete knee series, is often not obtained. Lots of people will check 3-view knee x-rays and they're not really sure why we would check the notch view, but in my experience, the notch view has been the most important view to demonstrate OCD lesions radiographically in the knee. If you have a clinical or radiographic suspicion for an OCD lesion, the MRI helps you to grade whether it's low grade, which is grades up to 3, or high grade, which is grades 4 and 5. High grade lesions warrant surgical consultation given their low likelihood for healing with rest alone. If you try non-operative treatment for any OCD lesions, patients are instructed to rest from impact activity, so no running, no jumping, for 3 to 6 months, depending on whether your lesion is disappearing on your x-ray and whether your symptoms are going away. I typically will follow patients every 3 months until their lesion has disappeared and they've become asymptomatic, and consult with surgery if we have progression, non-adherence, or we are starting out with a high grade. Now we'll move from the overuse injuries that present without clear injury mechanisms to the common acute injuries. You can think about these in similar categorizations based on which structures are involved. So muscles strain and tear, tendons rupture, and ligaments sprain and tear. In many cases for muscles and ligaments, some full tears can be managed without surgery, but concern for full tendon tears and some specific ligaments and muscles are too unique in their function to rely on other structures. They're not redundant with other things, and so they become functionally detrimental if they are fully torn. So we think about the supraspinatus full complete tear because the supraspinatus tendon will shorten over time and it makes surgery more difficult if delayed. So if your patient has an empty can sign that is really bad, you're worried about complete tears, checking that MRI early to make that early diagnosis and get them to a surgeon can be really helpful for their post-op recovery. The ulnar collateral ligament, or the UCL in the medial elbow, that also warrants orthopedic evaluation, especially in throwing athletes. And then any tears of the ligaments in the knee and any complex acute tears of the meniscus can contribute to lifelong pain, instability, and early arthritis if they're not diagnosed and treated appropriately. Dislocations of the shoulder and the patella, even if they are spontaneously reduced, also warrant orthopedics consultation because these have high risks for recurrence without proper treatment. These injuries are all more common in adults than children. The open physes in the children, again, are the weaker structures. So when you have high forces going through any kind of chain, the physis is the more likely one to widen and break instead of these other ligaments and tendons. On the right, you can see some examples of these. These are called avulsion fractures. We see the distal fibula with some variations of subtle or obvious fractures on the top, and then the photos on the bottom show tibial tubercle avulsions, which is essentially the acute fracture form of Osgood-Schlatter. As promised, here's the pelvic growth plates that fortunately do not use eponyms. I included these here because apophysitis at these locations, that chronic overuse injury, can be quite subtle with just a little bit of widening of the growth plates. But contrast that with avulsion fractures, it's more helpful for review to finding the corresponding locations more easily. So working counterclockwise from the top, we can see the iliac crest, the ASIS, the AIIS, the lesser trochanter, the ischial tuberosity, and the pubic symphyses. I could give an entirely separate talk on the topic of triaging orthopedics complaints, but I thought it'd be worthwhile to zoom out before we talk about fractures and sort of like scare people with that discussion. If you're on a sideline or in an outpatient clinic, an urgent care, an emergency room, your resources are all going to be different depending on your setting. So a patient that comes to see you for an injured ankle, they probably don't know if their bone is broken, if they have a minor sprain, if they have a full ligament tear, if they need a cast or surgery or just some ice. So in general, you should be concerned about fractures for patients who have too much pain to fully range an extremity or weight bear on it. The patients that have a concern for fracture needs an x-ray, and a patient who has pain with movement or weight bearing need the extremity stabilized in something like a splint or a boot for the ankle example, to prevent that painful movement and weight bearing. If you can't give them an x-ray, you can't give them crutches, a splint, a sling, whatever they need for their medical equipment, you can help the patient by recommending for them to go to an acute care setting for these resources. Some common pitfalls, two common pitfalls. One is slings are only really useful for the first 2 weeks of initial clavicle fracture management, but these are not used for other upper extremity fractures such as wrist fractures, elbow fractures. Just because you only have a sling doesn't mean you're helping the patient by giving this to them when it's not proper immobilization for a more distal extremity. For the second pitfall, if patients don't have the ability to get a crutch or a cam boot from your clinic, they are not going to do so just because you recommend it to go buy one. They will walk out of your clinic on their broken leg and they'll continue walking on it while they're waiting for Amazon to deliver, or they'll just perpetually avoid ordering it to see if it feels better the next day. These next two pearls, they are intended to help you know if you need to escalate care quickly with your initial evaluation. So if there's open skin near a fracture, they should receive orthopedics consultation. They probably will receive Keflex for osteomyelitis prophylaxis, and they'll get those cares quickly if you send them to an emergency room. And then lastly, if a patient has evidence of neurovascular compromise, reducing and splinting a fractured or dislocated extremity can help save the limb while you're waiting for EMS. So if you're confident, if you know how to do a reduction for something that's fractured or dislocated, you can help the patient significantly just by restoring vascular or neurovascular flow. So even though I prefaced fractures with the more scary triage stuff, fractures in children are very fun to treat. For today, we'll talk about some common fractures in kids just briefly with high yield sort of fracture sites focused in. First one is the distal radius. For any displaced fractures, including of the distal radius, patients should go to an emergency room for an attempt at reduction. Once the fracture is no longer displaced, or if it's minimally displaced, then we can place a short arm splint for distal radius fractures for about a week to allow any swelling changes, and then follow this up with a short arm cast or a long arm cast, depending on how much pain a patient has with elbow motions at the fracture site. So if they've got significant pain with pronation and supination of the elbow, you might consider the long arm cast to help keep the fracture stable. If your patient is reliable for stable fractures, you can opt for continuous removable bracing as a means of immobilization to avoid casting. If the growth plate is involved, as in the Salter-Harris fractures, once the fracture's healed, we still watch the physis for the distal radius for every 6 months for 2 years, or until the patient's physes have closed. We look at bilateral x-rays to compare them over time and make sure that the affected physis is not prematurely arresting. On these pictures, you can see an example of a subtle growth plate fracture on the top left, and you just see that subtle asymmetric widening on the lateral view there. You might refer patients with Salter-Harris 3, 4, or 5 to orthopedics for monitoring. You might also consider orthopedics referral for patients with intra-articular extension, the unstable both bone fractures, which also involve the ulna, for fractures that don't show evidence of adequate healing after prolonged immobilization, and for loss of acceptable alignment during your immobilization period. On the top right, you can see the initial green stick fracture. They return to their provider after 5 weeks, so not very close follow-up. And you can see that alignment has been lost at some point during this follow-up period. Loss of alignment is better to catch early, so fractures, we think about following them every 1 or 2 weeks until the patient's no longer tender and the x-ray shows good evidence of radiographic healing. So this is clinical and radiographic union, and it suggests that the patient no longer needs to be immobilized. Once the cast or brace is discontinued, I typically instruct patients to work on range of motion if they've developed some stiffness, which usually means waiting about 2 more weeks before returning to sports. This is a big reason why I like using removable bracing whenever I can. Stiffness won't usually be an issue for a patient who's been gently ranging their wrist and using a brace continuously otherwise. Finally, the photos on the bottom show 2 examples of distal radius fractures that remodeled without surgical intervention to help give perspective on how kids can still remodel pretty significantly over time for non-displaced fractures and for displaced ones as well. For the clavicle, if surgery is not needed, we start with 2 or 3 weeks of immobilization with a sling, followed by sport restriction to avoid falling down essentially until it's healed. Again, we're looking for radiographic and clinical evidence of union at follow-up. You should evaluate for concurrent shoulder injuries to address issues like rotator cuff injuries on your initial exam, and you should get a good skin exam to make sure the fracture is not at risk for opening the skin. I include an example here of normal swelling associated with a clavicle fracture compared to the true skin tenting with those photos on the bottom. Skin tenting, I have not seen this in clinical practice. It's pretty rare, but you might see swollen clavicles. And if you've never seen skin tenting, you'd be worried that you finally see it. It really does look pinpoint. For clavicle fractures, I typically advise that it's reasonable to return to high-risk sports, such as things with wheels, snow sports, and contact sports, up to 6 months after the fracture, but usually we're clearing them for these things and for normal sports at about the 2 month mark. But I try to be transparent with patients and with parents that waiting up to 6 months is reasonable if you want to keep your refracture rate as low as possible, that risk for refracture as low as possible. The textbooks will tell you that surgery is considered for any clavicle fracture that makes the length 2 centimeters shorter or more, if there's greater than 30 degrees of angulation, and or if there's displacement of the clavicle that's larger than 1 bone width. And the thought is that these parameters have decreased likelihood for proper healing. However, this important study from 2019 has changed many providers' approaches to completely displaced clavicle fractures. Hayworth et al. Followed over 400 teenagers with these types of clavicle fractures for 2 years and followed their outcomes after either operative or non-operative management. Intuitively, the fractures that went for surgery more often had shortening above that threshold of 2 centimeters, and these were often more often comminuted or in multiple pieces. The cases that went for surgery had significantly more complications, significantly more needs for unexpected second surgeries, but between the operative and the non-operative cases, there was no difference at the 2-year time point for risk for non-union or for refracture. So to consolidate what the textbooks are suggesting for thresholds, consider operative management versus what the patients are showing us in real life. As a primary care doctor, I would consult ortho for displaced clavicle fractures, basically expecting them to reassure me that it will remodel without surgery. Next, we'll talk about finger fractures. Similarly to the other fractures talked about, the deformities, greater than minimal displacement, more than 30% articular involvement, concern for prolonged non-union with immobilization, these are all great reasons to consult orthopedics. Patients with oblique or spiral fractures also need consultation for fixation because these fractures notoriously fall out of alignment because they're so unstable. Dislocated fingers, fractured fingers with displacement, and fingers with open fractures should triage same day to acute care for reduction and or antibiotics. If a patient's finger fracture is able to be managed outpatient, usually an aluminum splint provides adequate immobilization and adequate protection. If the fracture is related to the dorsal or the top part of the finger, you think about putting the finger in slight flexion in the splint to help that fracture unite. We think about slight extension for volar avulsions. Those are the ones on the palm side of the finger. For the thumb, patients have to use thumb spica splints, not aluminum U splints, because that also will immobilize the MCP joint of the thumb. We need to immobilize the wrist in order to prevent thumb abduction. So they can't get away with just the aluminum splint. If your fracture of the thumb, though, is just at the IP joint or the distal phalanx, and you only need to immobilize that IP joint, then you might be able to get away with that aluminum U splint. On the right, you can see how well teenagers remodel phalanx fractures without surgery as yet another example of that robust remodeling. I also included the example of a mallet finger on this slide, which is when the plate that anchors the extensor tendon on the top of the finger avulses off. This patient will show you an extension lag in this case. The treatment for this is something called a stack splint, which prevents the finger from falling into flexion while it's healing for 6 to 8 weeks, which is a very long time, but it's needed to allow that plate to re-anchor and the tendon to remain healthy. I will see patients every 2 weeks, instruct them to use their thumb like a pincer formation to maintain extension for the affected finger when they're changing or cleaning the splint. And then if they come to see me and they said that their finger fell into flexion during that time, the 6 to 8 week clock starts over again. Mallet fingers are good to refer to ortho because of all these sort of particular nuances, but any other finger injuries where you're worried about concurrent tendon injuries are good reasons to consult ortho. For the last common fracture, we'll talk about the distal fibula. This is most commonly sustained when someone rolls or inverts their ankle. The lateral collateral ligament complex of the ankle sort of yanks on the fibula and typically either pulls apart the growth plate or pulls a chip of bone off from its anchor point on the tip of the fibula. Salter-Harris 1 fractures of the growth plate can be noted with subtle widening of the growth plate on an X-ray, but are typically clinically diagnosed based on a patient's point tenderness over the area corresponding to the physis. You can see on this picture the little round marker that the patient used to identify where their pain was and put it very close to their physis in this example. You can also see very discrete medial physeal widening on this picture if you scrutinize that growth plate as well. If someone comes to you with an ankle injury and they're unable to weight bear or you're worried about a fracture, they need a cam boot because they can't walk, they might need crutches, and they need an x-ray. So if you don't have the modalities, then referring them, like we just talked about in the triage slide, is important to get them to acute care. If you think that they have a fracture and you get an x-ray and you don't see one, I will typically reevaluate patients in 1 or 2 weeks to assess for any fracture remodeling. If the concern for fracture is ruled out, we'll essentially see an identical x-ray, especially if their symptoms are getting better and they're able to start weight bearing. So at that point, for ankle sprains, I'll transition patients to a lace-up ankle brace for protecting against their inversions for at least 1 to 2 months, but they can use them indefinitely if they want. The lace-up ankle braces have demonstrated superiority to other types of bracing and to ankle taping, so lots of people use them as prophylactic for ankle inversion injuries. Finally, I'll give patients home exercises and a PT prescription for ankle strengthening and proprioception. When someone rolls their ankle, they're at risk for future inversions with greater risk each time it happens. This is likely because the ankle has demonstrated weakness, so they've sort of identified their profile, and or because the ligaments become even more lax or loose after sprains. This resource is one that I can't recommend enough. It's written for a primary care provider and it features step-by-step management that's outlined similarly to how we talked about these common fractures, but it's for every bone in the body, organized by chapter. I know one sports medicine doctor who shamelessly leaves this text open as they're sort of like up to date for fractures in clinic. You do not need to memorize every reason to consult ortho. You don't need to memorize every way to immobilize a different type of fracture, especially if you have a reference like this. So we reviewed how to identify and treat some of the most common overuse and acute injuries in children. Now we'll discuss an increasingly important aspect of injury prevention in young athletes and sports specialization. Over the last few decades, young athletes are increasingly choosing to specialize in a single sport. We think about labeling an athlete as specialized when they compete in a single sport for 8 or more months out of the year and when they do not spend similar amount of time playing another sport. Surveys of children and their parents suggest mostly parental motivations for this emphasis, with goals of sport and financial success with the goal of mastery of a single sport. However, most kids in the United States stop playing all sports altogether when they start high school, attributed to the phenomena of having to make the team, and this includes the specialized kids. And this means that for most of these kids, virtually none of them will achieve sports success in the form of collegiate participation after high school. And this is true, virtually none of them will participate in college, even if you are selected for a high school team. So this idea of sports success, narrowly defined as making money from it or something sort of similar or adjacent, is that a good way to define sports success? Is a young athletic kid who remains a healthy athlete lifelong but doesn't play on a college team or receive a scholarship or go pro, is that athlete considered to be unsuccessful in sport? But let's say you still want to shoot for that 1% chance. Does it hurt to try and master a sport by specializing to make a college team? And maybe that will pay off with that little bit of chance. Our studies of elite professional and Olympic athletes suggest that these high-level athletes were usually not specialized as young athletes. Our studies of Division I athletes also suggest that they typically wait around age 16 to settle into a primary sport participation. The thought is that these multi-sport athletes are self-selecting into more elite categories because they're learning more adaptable movement patterns, they're protecting themselves from overuse injury by cross-training, and they're not getting burned out by playing the same sport for the first 2 decades of their lives. So maybe specialization doesn't really help your chances based on what we're seeing in the high level athletes, but does it hurt to try? It seems very likely. Each of these studies that I've highlighted deserves their own journal club session, to be honest, but this is a compilation of 12 recent studies that highlights the commonly corroborated association between high degree of specialization and various injury risks. The studies evaluated in this 2019 analysis led the authors to the concerning discussion point that higher rates of pediatric type injuries, such as apophysitis, were apparent with specialization, but also that the degree of overuse injuries associated with sports specialization trends athletes towards the adult injuries later in life. Neeru Jayanthi uses the example of patellar tendinopathy, which is an injury now studied commonly and treated commonly in clinic for young teenagers, but it was previously described as rare injuries for adolescents in some articles from the 90s about patellar tendinopathy. This is now a very common one in kids. The evidence associating sport specialization with injury risk has been so resounding that virtually every relevant academic society's position statement discourages it. Dr. Jayanthi has also contributed a study in an attempt to risk stratify other variables that might be confounding the issue with sports specialization. What if it's related to the volume or the overscheduling or something else that is just going along with the fact that they're specialized? This study of over 1,200 young athletes found injury risks to be associated with specialization irrespective of hours per week of activity and irrespective of growth rates in injured patients. They also found that participating in a single sport for more hours per week than a child's age was associated with significantly increased risk for overuse injury. Based on this study and the position statements from the societies that I showed before, we talk about these rules of thumb to be a sort of harm reduction when we think about counseling parents who are committed to sport specialization for their child. I describe that their child's more likely to need to come see me in clinic for an injury if they play more hours per week than their age, do not take 2 days off per week from the primary sport, especially structured play, and if they don't have at least one off season during the year where competition and performance is not emphasized as much as maintenance, rest, and rehabilitation for any injuries. We think about the off season duration of 3 to 4 months. Unfortunately, sport specialization is also objectively associated with burnout in large studies of thousands of youth athletes. I describe to parents who are still exploring options for sport or with young children who are still trying new things to keep encouraging this concept of sports sampling. The concept of the fitness paradox is a powerful one. I'll illustrate this a little bit more on the next slide. People who are healthy and active as children are more likely to be healthy and active as adults, and vice versa. A paradoxical outcome for an elite athlete who is specialized but then burns out, gets injured, or both, withdraws from sport, and then becomes a sedentary adult because withdrawal from the sport that gives them identity as an athlete means withdrawal from physical activity in general. That's a terrible paradoxical outcome, in my opinion. So, when I'm speaking with patients and parents about sport participation and injury prevention, especially, I try to highlight the many positive aspects of sport and physical activity other than potential future financial success. Longevity in sport and physical activity, in my opinion, is the meaning of life and is the key to a long and happy one. But longevity in sport does not mean playing in the NBA. Here's some references that I use to source my talk. And here's some information about how to get in touch with our clinic and how to get in touch with me. Thanks for your time.